Hello everyone, welcome back to the channel. My name is Aryan Malik. This is Study with Me series and today is day 22. We'll be continuing our discussions on fundamentals of nursing and today we'll be talking about pain management. So it can be personal, physical and emotional. Something that may feel very painful to one person might not feel painful to another person. Now, let's look at what are factors affecting how pain is perceived by an individual, ethical and cultural variables, development stages, environmental and support people, and previous pain experiences. Some people might see pain as a good thing in certain situations like working out, or even, for example, a patient on a chemotherapy feels like they're having pain, but it is because the treatment is working for them. Now, let's dive into types and sources of pain. First is acute pain. How I see it is short term pain. So, anything which is sudden, severe is characterized as acute. For example, bruising or a new bump. Chronic pain is more like long term pain and is associated with many long term illnesses like cancer. So it is recurring over an extended time. For example, back pain. Next type of pain is referred pain. So the feeling of pain in one part of body that is caused by the pain or injury in another part of the body. So for example, chest pain from a heart attack could trigger pain in the jaw. Next is phantom pain. It is a pain that feels like it is coming from a body part that is no longer there. And for example, in case of amputation, say a client's leg or part below the knee was amputated, they are feeling some pain. So we as healthcare providers characterize this as real pain and treat it accordingly as well. Some time ago, the physicians thought that this was more like a psychological pain, but recently experts have determined that this pain is arising because of the sensations in the brain and the spinal cord, so it should be considered as a real pain. Now, let's look at gate control theory of pain. This asserts that non-painful input closes the nerve or basically gates to painful input, which prevents pain sensations from traveling to the central nervous system or the CNS. So the mechanism is basically the gates built into normal pain pathways which then opens the gates and pain impulses are transmitted to the brain, and then the gates close and pain impulse is reduced. Now let's look at diagnosis of pain. So it encompasses location, description in a way if it's burning or aching, and timing or with activity. So it's the pain that occurs with activity and what is the time of the day. Another acronym that we use very often when having a diagnosis of pain is OPQRST. O stands for onset, which is basically what caused the pain, and P is for provocation. It's what's the like trigger of this pain and what makes it better or worse. Q is quality. Is it sharp, dull, stabbing, or burning? R is radiating, which means is it traveling to the other parts of the body. S is severity, like on a scale of 1 to 10, how severe is the pain? with 1 to 3 being less pain or no pain. I think so. And then 4 to 6 being moderate, and then 7 to 10 would be severe. And stands for time. Again, what time does the pain occur? That does occur at night or in the morning, and what causes the pain basically. Now let's look at pain manifestations and the signs and symptoms. How we can determine that a client is going through a pain or what they are describing as pain. So what are other factors that we can determine that tells us that yeah, there is actually a pain. Though one should always be careful that if the client says they are having pain, we always believe they are having pain. So the client looks pale. This usually happens when they are experiencing severe pain. Then they have diaphoresis, meaning sweating. The client is sweating. They have restlessness and tachycardia, meaning heart rate over 100. Then their fist may be clenched. They have high blood pressure, over 140 systole, and they are also experiencing nausea and vomiting. That occurs mainly in the case of acute pain, and they are feeling dizziness or fainting again in case of acute pain, and they are experiencing anxiety or fear. This occurs usually during chronic pain or trauma. Now let's look at some pain management strategies that we as registered nurse can imply or apply. Formulate a plan, educate client to make a realistic pain goals, keep client involved in strategies to how to manage pain, always acknowledge the pain. Only about 5% of pain reporters are found to be exaggerating, and reduce anxiety about pain. Pharmacologic treatment, non opioid pain meds, you can give them NSAIDs, acetaminophen, or other word for Tylenol, opioids, or co-therapy. Non-pharmacological treatment includes breathing technique, distraction like TV, reading, games, hot or cold application, rest, meditation, massage. Well, this marks the end of this session. I hope you found this helpful. Please stay tuned for more videos that will be coming out in the future. Thanks for watching.